This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So today our podcast is about HFpEF, or heart failure with preserved ejection fraction. And of course, my co-host is Dr. Jason Guichard, who is a heart failure specialist in South Carolina with Prisma Health. And we do have a very special guest, who's Dr. Shane Nanayakkara, who is a cardiologist and specializes in actually structural and interventional cardiology, but also has a PhD, and his main focus of his research was in HFpEF. So Shane comes from Australia, and we're recording this on Saturday morning. Of course, it's Sunday morning for Shane. And gentlemen, welcome, and thank you for taking the time to be with MyHeart.net.
Thank you very much for the invitation. Very much appreciate being on the podcast and look forward to a healthy discussion.
Sounds great. Well, we know that heart failure is usually when the heart is unable to pump sufficient blood to maintain blood flow and meet the body's need. Heart failure is a common condition, but also can be fatal. It affects approximately 40 million people globally. Overall, around 2% of adult population have heart failure. And in those over 65, this increases to 6 to 10%. It's in the cardiovascular health study that included almost 5,000 elderly patients. Heart failure prevalence was approximately 9%, of which the majority had preserved ejection fraction, or HFpEF. So let's start with Shane. What is HFpEF?
And surprisingly, that is one of the most difficult questions to be able to answer. Part of it is where we started with heart failure. Decades ago, we have these definitions. A lot of people base it off the Framingham criteria that talk about heart failure being this constellation of signs and symptoms that we associate with the diagnosis. And that includes things like weight gain, shortness of breath, swelling of the ankles or peripheral edema, but also signs that we might detect on examination, like a third heart sound. Now, those signs and symptoms are really focused more on heart failure with reduced ejection fraction. What you might say is the more typical type of heart failure that we treated a long time ago. And more recently, we've understood more about what heart failure with preserved ejection fraction is. In simple terms, we start with a patient who has heart failure signs or symptoms, not necessarily the full constellation, but most classically exertional dyspnea or shortness of breath on exertion, together with an ultrasound of the heart demonstrating normal pumping function. Now, that pumping function is measured through something called ejection fraction. Ejection fraction is a measure of when the heart is relaxed, how much blood it has, compared with the fraction of blood that's remained after the heart has squeezed and pushed all that blood out. Now, we know that despite the heart pumping normally, and I say that in inverted commas, now when that ejection fraction is normal and people feel short of breath, we think, could this be heart failure with preserved ejection fraction? It's important to consider that there are many mimics for heart failure with preserved ejection fraction. And this isn't just around HFpEF, but there are other conditions. For example, it's been talked about on the podcast before, mitral regurgitation. People with a severely leaky valve can look like they have normal pumping function and of course feel short of breath, but that's due to their valve problem. And there are others like this, myocarditis, an inflammation of the heart muscle, or another condition, constrictive pericarditis, where the lining around the heart is affected. One of the things we have to make sure is that we're excluding a whole raft of these mimic conditions before we say that a patient might have heart failure with preserved ejection fraction.
Well, thank you very much. Of course, we're defining heart failure with reduced ejection fraction, someone who has an ejection fraction of less than 40%, and normal is pretty much above 40%. But really, truly normal is really an ejection fraction that is, between 50 and 60%. So Jason, for example, it seems like in the patient population with preserved ejection fraction, we may have 2 or 3 different patient categories because you have patients that have, kind of this mid-range, this ejection fraction, this is kind of in between, is like between 40 and 50%. And you don't know whether these patients had a very low ejection fraction in the past and somehow they're coming up, or you don't know whether this is someone that had an ejection fraction that was 60% and now it's coming down. How do you sort it out?
Yes, it's a good question. To summarize what you had said, ejection fraction less than 40% is considered a reduced ejection fraction, and ejection fraction greater than 50% is considered, preserved. And then that kind of middle range between 40 and 50 is the so-called mid-range EF, or also borderline, which was early on called HFpEF, which is interesting. So we had HFrEF, HFpEF, and HFpEF. So cardiologists, especially heart failure cardiologists, like to make things as complicated as possible. So we use these big words to make sure that we sound smart and people stay confused. But instead of HFpEF, which is obviously very close to HFpEF, we called it mid-range. So a mid-range EF is quite interesting. There's not much known about mid-range EF. There are no real clinical trials, looking at mid-range EF, but there is some information that we know. So the trajectory or the path that the patient is going through kind of in life, in their clinical scenario through the mid-range is important. So as Alain kind of talked about, if you had a normal ejection fraction and you get reduced to mid-range, prognostically speaking, those patients do worse. So this is something that would be considered a red flag. Now, you could also be going the other direction. So patients that had a low EF or HFrEF, and then were put on medications or other things and then increased to the mid-range. So that trajectory, those patients, as they're increasing, do better. So we do know that not all mid-range ejection fraction patients are created equal. It depends on which direction that the patient is going, where their trajectory is, a trajectory down or is a trajectory up, largely defines the prognosis for these patients. So that's probably a good thing for patients to know, a good thing for providers to keep in mind. But ultimately trying to figure out, what has caused the ejection fraction to change, whether it has gone from normal to low or from low to mid-range, is important.
So far we know that HFpEF is someone that has a shortness of breath and may have some ankle edema and has on the echocardiogram an ejection fraction that is greater than 40%. And we'll leave it at that for now, but we'll keep kind of expanding, I guess, and define maybe a little bit better, because obviously we need some other factors to really make a diagnosis of ejection of HFpEF, and we'll talk about that a little bit. But Shane, tell us a little bit about what causes HFpEF. I mean, because it seems like HFrEF or heart failure with a low ejection fraction is a bit easier to understand. You have like an event, like a heart attack, or you have an infection, or you have a myocarditis, and it destroys, or you get necrosis of the heart cells, the cells die, you have apoptosis, and you have reduced ejection fraction. With HFpEF, or this preserved ejection fraction, it seems like it's a comorbidity-driven, pathology. I mean, what drives this HFpEF? What causes it?
It's a great question. When it comes to looking at HFpEF, a lot of different researchers have come at it from different angles. There's this famous analogy of the blind men feeling an elephant and telling each other about what this creature is without understanding it. And for each of us in research, it's been about bringing our own, weights and biases into thinking about what this condition is. Realistically, it's a sequence of events that lead to a patient developing at least one of the phenotypes of HFpEF. If we start at the top, we have our risk factors or our comorbidities. Primarily, this has been around aging, obesity, the metabolic syndrome, high blood pressure, as well as other contributors like the sedentary state, chronic kidney disease, as well as the presence of coronary disease. Together with that is the influence of gender. There is a gender bias in some early studies suggesting that women are more likely to be predisposed to HFpEF. Increasingly, that's being teased out further and further, and perhaps understanding that there is a gender difference in how HFpEF develops or manifests in women versus in men. Those risk factors then lead to the next level, which is the tissue and cell pathology part of it. And that leads to some evidence of low-grade systemic inflammation. There are all kinds of biological factors that this inflammation then causes a downstream signaling process that becomes disturbed. And those signaling processes, so how cells communicate with each other, or whether the heart itself becomes fibrosed and where it develops fibrosis. Is that in the left ventricle, the main pumping chamber of the heart, or in the left atrium, the reservoir that holds blood before passing it on to the left ventricle? Both of those get affected. And of course, there are signaling factors, not just the cells themselves, but messengers that also get disturbed as part of that. Then those factors lead to some kind of structural adaptation. And that might be in the left ventricle or in the left atrium, where the shape of the heart is either changing or its ability to deal with a volume of blood is changing. That then leads to what we often measure in the cath lab, abnormal hemodynamics. And that means that the pressures in the heart are changing. Often in HFpEF, the pressures are normal at rest, and we'll talk more about that later, but particularly with exercise associated with the patient's symptoms developing, we see abnormal hemodynamics. And then that can later lead to secondary organ dysfunction. These patients might develop worsening of their chronic renal dysfunction or develop pulmonary congestion and feel more short of breath. And that whole cascade is what then leads to the development of what we call HFpEF.
So basically, you're talking about comorbidities driving some microvascular sort of inflammation, throughout the body, affecting the heart muscle cell in some ways or another to develop, either some scarring or some hypertrophy or kind of like enlargement of some of the heart muscle cells, and then developing some malfunction of the heart function.
That's exactly right. All of those factors lead to HFpEF. Where we have interest in research is finding out what is that combination of comorbidities that leads to what HFpEF becomes, and what is it that's unique about those patients who have hypertension and diabetes and obesity that get HFpEF versus those with the same comorbidities that may not develop the disease. And clearly there's an interaction of these factors that's yet to be fully understood. One thing I will say with that is that there is this increasing understanding of the phenotypes of HFpEF. When we said before, we talked about heart failure with reduced ejection fraction, people with an ejection fraction less than 40%. They clearly have a uniting factor that brings them together, the fact that their ejection fraction is low. In HFpEF, it's almost the opposite when it comes to our definition. We're saying that because you have something normal about you, i.e. your ejection fraction is preserved, that will group you all together. And so within that, there is likely to be different phenotypes. If I can analogize to something like cancer, in cancer, we started with a collection of signs and symptoms, say weight loss, for example, that then later was understood to be associated with certain cells that are rapidly multiplying. But we get more and more understanding in cancer that, yes, we understand that there's separate breast bowel cancer, for example. But then within breast cancer, we find certain phenotypes of hormone receptors that have improved our therapy. And what we're finding more and more with HFpEF is that there may indeed be these separate phenotypes, people who are more cardiac specific or extra cardiac specific, that lead to the same symptoms, but how they got there is very different. And that might be dependent on their comorbidities that led to that in the first place.
Yeah, and I'd like to echo what Shane has said. Probably the most exciting thing to happen in the HFpEF world, which has been very little up to this point, sadly, has actually been the differentiation of these phenotypes. Because, as Shane was saying, HFrEF, so low ejection fraction, less than 40%, the two main kind of etiologies there is what we call an ischemic cardiomyopathy, so patients that have, heart disease and heart attacks and that sort of thing. And then we call a non-ischemic cardiomyopathy, so patients that don't have heart blockages, but have other reasons to have a low ejection fraction, whether or not that's, a viral myocarditis, or chemotherapy agents or others. We were able to kind of identify the etiologies of low EF patients, and mountains and mountains of research and mountains of clinical trials have gone into that. Where HFpEF has really fallen short up until just recently is we didn't know what it was. We didn't know what caused it. We didn't know which patients had it. It became very tricky to study it. So, the development of phenotypes, especially here over the last couple of years, has been revolutionary in the HFpEF world, because once you can understand a disease process, once you finally meet that, then you can start treating it. Up to this point, HFpEF really has been a great big question mark. So some of the major phenotypes that have been, kind of described and figured out over the last couple of years, hypertension is a big one, probably the most common cause of HFpEF, and then the obesity, diabetes, metabolic syndrome, heart disease, coronary disease would be the third. Fourth, which is also a big one, probably about 15% of HFpEF would be cardiac amyloid, which, we've talked about in some of our podcasts already. The fifth one is pulmonary hypertension. So these patients with, HFpEF, they develop a little bit of increased left-sided filling pressures, and they have this abnormal response, this out of proportion elevation in pulmonary pressures in their pulmonary hypertension, way out of proportion to just the little bit of dysfunction they have on the left side. And these patients get incredibly symptomatic. So there's a unique combined pre and post capillary pulmonary hypertension phenotype that's beginning to be kind of understood and recognized. And then six would be renal disease, CKD, ESRD, and then the last would be aging. So, aging actually is a cause of HFpEF. Obviously, it's not really something we can, do about at this point, other than just good lifestyle changes. But being able to differentiate and being able to describe some of these, phenotypes has been revolutionary in the way that we treat patients, and hopefully revolutionary in the future about how we treat them. So really, that has been probably the hugest advance in the HFpEF world, which I know isn't very exciting, right? Just being able to characterize patients. People like treatments and big clinical trials that show all this. But really, we have done a very poor job describing these patients, HFpEF patients. And I think for the first time here over the last couple of years, we've really been able to get a pulse, on the situation. And one of the biggest ways, one of the biggest things to come up is actually cardiac amyloid, which has been, great to be able to see that disease process kind of rise to the top as something that people are starting to realize is an important cause of HFpEF and now very treatable.
So, Jason, it seems like you're describing a little bit who are these people, what is the clinical syndrome? And with the another mnemonic, I don't know if we need another one, but that H2FpEF, where you have like this, the weight, which is heavy, as well as hypertension. You have the F for AFib. You have the pulmonary, P for pulmonary hypertension. The E for elderly, the greater than 60. And then F for the filling pressure that you document hemodynamically. That pretty much summarizes what is a HFpEF patient.
I think where that's become really useful, that scoring system, is around this idea that patients are presenting to you with unexplained dyspnea. So, that scoring system from Dr. Reddy and Dr. Borlaug from the Mayo, they've done amazing work when it comes to HFpEF. And so if we look at that scoring system, if a patient presents to you in the clinic, let's say, and they have unexplained dyspnea, how do you determine whether this might be HFpEF versus something else? And what that allows you to do is to determine a pre-test probability. You apply that scoring system, and they provided a very nice nomogram in their paper to say this is likely or unlikely. I will say together with that, there's also the HFpEF score, so the HFA-PEFF. And so guidelines around that, including the European Society of Cardiology guidelines, talk about not only those clinical factors that they mentioned there in the HFpEF score with some echo features, but they've talked more specifically about what biomarker cutoffs should you use, what morphologic markers should you use for the size of the left atrium, what should you be looking for on tissue Doppler, again, with this idea that you're assigning a pre-test probability for your patient. It's really important to keep in mind that this isn't necessarily diagnostic of HFpEF. These are there to encourage you down the investigative pathway for a particular patient. And again, to keep in mind that these do predominantly rely on resting measures, and that HFpEF is often a disease that develops with exertion. And as we talk about investigations a little later, we'll find that some of those tests that stress the patient are the ones that are going to be most useful for making the diagnosis.
Well, let's talk about that now. How do we make a diagnosis of HFpEF? What is the typical workup, Jason?
So yes, we've kind of talked about it already. The HFpEF score. This is, probably where I'm going to differ with, some, providers. So kind of taking a step back for me. So, HFpEF carries a very poor prognosis, right? Both HFrEF and HFpEF together. The rule of thumb is about a 50% mortality in 5 years, right? So, this is worse than most cancers. I think we get numb to heart failure because there's so many people that have it. So many people carry that diagnosis. But when you really kind of sit down and think about it, HFpEF and HFrEF carry very poor prognoses. So with that, my personal practice is I'm very aggressive, so to speak, when trying to figure out this diagnosis. And for me specifically, I use right heart cath, right heart cath with exercise, right heart cath with fluid challenge, various invasive hemodynamic studies to either prove or disprove whether or not someone has, elevated filling pressures, which is kind of the diagnostic hallmark of HFpEF for patients. So I, do use pretest probability scores, either formal ones that are out there or just kind of clinical ones, kind of just based on, clinical experience to, understand and maybe even treat these patients, but on the front end, decide whether or not someone deserves a right heart cath to actually try to figure this out for them specifically.
Jason, let me back you up a little bit. You're already in the cath lab, but I have this patient still in the office with you, and he's short of breath. He's got an ankle swelling. What do you do in the office, like with the history and the physical, and what do you find on EKG on these patients? And then we could talk maybe about the echo that is done also in the office.
Gotcha. So yes, all the typical things. So I know that Shane kind of touched on some of them at the very beginning, some of the clinical findings, some of the physical exam findings, some of the EKG findings and echo findings. There are different parameters on the echocardiogram, looking at left atrial size, various kind of measurements for filling pressures, biomarkers, BNP and troponin, NT-proBNP and regular BNP. So all of those can add to the pretest probability, which I guess I was kind of talking about before. It was just wasn't specific, but taking in all that information together, when trying to decide, what to do with the patient. I will say that some of these things are helpful, but some of these things can also lie to you and say that things are normal when a patient's sitting there telling you that they're short of breath when they're going up a flight of stairs, and this is new for them. So there are lots of things that we can do in our office to kind of decipher or figure out if someone has a high pretest probability for HFpEF. And we can take that information and, leave it as it is, or go on to other invasive studies to try to figure that out. That I guess we can talk about after some of these regular tests.
So let's talk, Shane, let's talk about that echo a little bit, because it's done, so many times. It's so easy to do. Jason has mentioned some left atrial enlargement, which obviously is not normal. The ejection fraction appears normal. It's maybe 45% or 50% even. But is it really truly normal? I mean, is there something else that you look at on the echo that really tells you maybe that systolic function or that pump function is not completely normal?
Right, and I'll expand a little bit just on the EKG part, and then I'll move on to echo. One thing to note about the ECG, there are probably three key things to keep an eye out for specifically in a HFpEF patient. One is the presence of atrial fibrillation, common in heart failure in general, but there's a 30% overlap of AF and HFpEF both ways. 30% of AF patients have HFpEF and 30% of HFpEF patients have AF, and they really act as vicious twins against each other to worsen symptomatology. So really aggressively screen for that. Part two is that left ventricular hypertrophy is a common occurrence, as mainly because of hypertension over a long period of time. And the third thing is to look out for small complexes in the presence of cardiac amyloidosis. Around 13 to 14% of HFpEF patients have amyloid as a diagnosis, so it's surprisingly common, something we should be keeping an eye out for. When it comes to echocardiography, there are key parameters that are mentioned in the guidelines and various documents around what we should be looking at. Let's start with left atrial size. It makes sense that as the left ventricular function gets or as the left ventricular diastolic function gets worse, as the ventricle gets stiffer, that the left atrium becomes larger. And so there's a parameter known as the left atrial volume index that, if greater than 34, is suggestive of HFpEF. Now, it is important to keep in mind of two things. One, left atrial volume may not get larger in every patient. The same stiffening process that happens in the left ventricle might also occur in the left atrium. And in fact, there is a stiff LA syndrome where this atrium, you can imagine, stays small and non-compliant and transmits those pressures straight onto the pulmonary circulation. And so having a large atrium isn't purely a prerequisite for HFpEF. The other part to keep in mind with the left atrial volume index, I should say, is it's indexed to body surface area, not to height. And so you can imagine as a patient becomes more obese, their body surface area increases. And so parameters that are indexed to body surface area are potentially less reliable. The second part to the echo, aside from the left atrium, is this measurement of filling pressure. This idea of filling pressure is this way of estimating the pressure within the left ventricle, let's say at the end of diastole. Now, non-invasive estimates of that using echo use something called Doppler, where we're either using the tissue or the flow of blood through the mitral valve into the ventricle to be able to estimate that pressure. And realistically, they are variably sensitive or specific for measuring that pressure. At rest, they are somewhat unreliable, and to give specifics is very difficult. We know when these parameters are very abnormal that it is sensitive for the picking up abnormal filling pressure. But when these parameters are normal, don't assume that the patient doesn't have some abnormality with diastolic function. The other thing is looking at the wall thickness. We know that a proportion of patients have an increased left ventricular mass index, an increase in their LV mass, predominantly, again, due to hypertension and increased left ventricular wall thickness. But again, just keep an eye out for that mimic amyloidosis, which also causes an increase in left ventricular wall thickness and therefore left ventricular mass. And so again, when you see those patients with thick walls, if you're looking at the imaging itself, then you might see that speckly appearance, although that's less sensitive than it used to be. But you must just keep an eye out that this could be amyloidosis. Aside from that on echo, there are two other parameters that are becoming of increasing interest. You mentioned, Dr. Bouchard, about left ventricular systolic dysfunction that might be subtle. We have two ways we measure systolic dysfunction: ejection fraction, which picks up gross systolic dysfunction, and left ventricular global longitudinal strain, or LV strain. And that picks up subtle systolic dysfunction. And so a proportion of patients have a low strain, or an abnormal strain, I should say, in HFpEF. That is associated with some hemodynamic abnormalities. But again, not every patient with HFpEF has that. And then there's left atrial strain. This is potentially going to become the more sensitive correlate with filling pressures and pulmonary capillary wedge pressure over time, but it's the focus of further research at the present time.
Is there a role for a stress test in patients with HFpEF? Is it mostly to rule out coronary artery disease, and that can be quite prevalent in these people, or do you look for some other things?
So absolutely, there's a role for stress testing. You know, there's a famous saying that if you want to assess exertional breathlessness, you need to exert the breathless. And so a condition which manifests primarily with exertion is something that makes sense, that we need to do some type of dynamic challenge to the patient to bring out their abnormalities. Now, non-invasively, that's primarily done with stress echo. And yes, we can look for abnormalities like an increase in their pulmonary pressures with exercise. Not every patient demonstrates that, but if you can get a good signal, it's a very useful parameter to pick up what might be going on with this patient, whether it could indicate you towards HFpEF. Less work has been done so far with developing tissue Doppler with exertion. Part of the problem is around getting a lot of these parameters measured while the patient is coming back from exercise or during exercise. It's challenging. And I will go on, later we'll talk a bit more, but Jason mentioned the important role of right heart catheterization with exercise. This is the gold standard investigation to measure or to diagnose HFpEF. Normally, our pulmonary capillary wedge pressure, our left atrial pressure, is less than 15 at rest and less than 25 with exertion. So with patients who have HFpEF, a significant proportion of them have normal pressures at rest. But while lying down perhaps and doing supine cycle ergometry or sitting up and cycling, whatever that exercise challenge may be, soon as we start exercising them, we see a very rapid rise in their left atrial pressure or their pulmonary capillary wedge pressure, consistent with HFpEF, going beyond 25. And a lot of these patients have normal echocardiograms, normal systolic function, but often normal parameters of diastology. But as soon as we exercise them, we see this rapid rise in pressure that correlates with their symptoms.
And I guess you can see whether the pulmonary artery pressure is really proportional to the elevation of the wedge or filling pressure, or whether you're dealing with some other phenomenon that is, pulmonary arterial hypertension of some sort, can be quite, bad for some of these patients.
That's exactly right. And I think it's very important to keep in mind the patients presenting to us with unexplained dyspnea, and all of these tests are a way of delineating what that might be. Now, it may be HFpEF. Some studies say around 50 to 60% of unexplained dyspnea is HFpEF at the end of the day, but it may be other things. And these tests, particularly our non-invasive tests, are a really good way of starting to get patients down the right pathway to find the cause.
Obviously, in the cath lab, we're going to do a left coronary arteriogram and find out whether there is, a component of ischemic heart disease or blockages in the coronary arteries. But so I'm interested that, we're still wanting to make a diagnosis, Jason. I like these new techniques. Obviously, we discussed amyloidosis before, where we would probably order a technetium pyrophosphate scan, maybe order a magnetic resonance imaging scan or a CT. Where would you go, for that, to try to rule out other diagnoses that could cause HFpEF or could mimic HFpEF?
Yes, some of the other, phenotypes that we've talked about kind of already that would be important to rule out. The biggest one would probably be cardiac amyloid. It's got very unique kind of testing exams that can pick this up, either cardiac MRI or with the technetium pyrophosphate scan. In addition to that, additional labs to rule out AL amyloid. So, given the prevalence of, amyloid in the HFpEF population, I don't know if I would recommend universal screening, but for patients that kind of meet, that kind of high pretest probability, for us, kind of symptoms way out of proportion to what you would expect. Number two would be discordance between, LVH on an echocardiogram, but no LVH on an EKG, are all kind of two, kind of big red flags. There's also some kind of hemodynamic, red flags that you can see on right heart cath as well. And then, of course, the demographic. So at least in the United States, older white males are kind of the prototypical demographic for the wild type TTR amyloid. And then, in our area, African Americans, have a high TTR mutation, so the valine to isoleucine mutation. So if they meet kind of those clinical criteria and the demographic criteria, I think that it's reasonable, to rule amyloid out in those patients. Those with a TAVR, TAVR is a huge patient population there, obviously overlapping with kind of older patients. But that's a very reasonable place to start because that's very treatable, right? Of the different phenotypes, this is kind of the unique one that has, its own special, medication and other things, which we've talked about previously. So not missing this in the HFpEF patients, I think is important, mainly because it's treatable. And then it's not all just HFpEF. We talked about HFrEF. There's a little overlap there with amyloid, just to kind of throw that plug in there. But yes, it's important to identify, the different phenotypes so that they can be treated for sure.
I think on the amyloid point as well, one of the other findings on echocardiogram can be the presence of very low tissue Doppler velocities. So if you're seeing tissue Doppler velocities that are less than 5, and some people call it the 5-5-5 rule for each of the points that we measure it. If you see that low tissue Doppler velocity, we should be thinking about amyloid. And then the other thing to keep in mind, as Jason mentioned, is always search for underlying malignancy as a potential comorbid cause of the high amyloid in the first place, but also that these patients are at a higher risk of stroke. Some people do talk about even anticoagulating amyloid patients outside the presence of atrial fibrillation, although that's controversial, but keeping in mind that these patients are at a higher risk of stroke, so really evaluate their bleeding risk early. And they're also associated with autonomic dysfunction, so measuring postural blood pressure is very important. One clinical finding is if you ever have a patient who's a bit on the younger side, who's had carpal tunnel surgery done, that should twig you to thinking maybe this is amyloidosis.
or spinal stenosis. Well, let's talk about treatment a little bit, because, in the field of heart failure with reduced heart function, we have so many, positive clinical trials, and we've really broken down to really 4 great classes of medication that it really helps those patients, particularly the beta blocker, the ACE inhibitor, or ARBs or ARNI. And we have then the spironolactone or mineralocorticoid kind of agents, and finally newly this year, the SGLT2 inhibitors, which we mentioned in one of our podcasts. But in HFpEF, I mean, it's been very frustrating, because for the last 20 years there's been only negative clinical trials, but maybe if we kind of could discuss that a little bit, there's some of the clinical trials, there are some pearls, or maybe some classification, or maybe some group of patients that could really potentially benefit. So what could we get for these last 20 years of clinical trials that have been negative for HFpEF? What could we get out of each of these maybe trials, or maybe not each of them, but at least some of them? Let's start, for example, with CHARM, which was maybe 15, 20 years ago, studying candesartan, and
Right. I think going through each of these drug classes might be the easiest way to frame it when we're thinking about therapy. So CHARM Preserve back in 2003 was looking at angiotensin receptor blockers. They had over 3,000 patients. And again, looking at people with an EF more than 40. And it was overall a neutral trial. What they showed was that there was a greater benefit of the medication in patients with a lower ejection fraction. One important point about how the trials have been over the last 20 years and why we've got some therapeutic nihilism around HFpEF is this varying definition. How we defined HFpEF 20 years ago is different to how we define HFpEF now. In fact, if you look across all of these trials, we had an EF of 40% back then, and now we use the accepted definition of EF more than 50%. Some people used BNP cutoffs before, some people didn't. And of course, how much of those parameters you include, particularly whether the patient had been hospitalized for their heart failure, affected how the trial ran. So that heterogeneity in the definition has led to some of that therapeutic failure. If we look at other drugs, so there was PEP-CHF, a trial that looked at ACE inhibitors that showed some improvement in the 6-minute walk distance, but there was a high discontinuation rate of the therapy. And then looking at sacubitril valsartan, clearly a blockbuster when it came to HFrEF. This year, not as positive a result when it came to HFpEF. So there was potentially some subgroup analyses that showed some benefit, but again, not what we saw in HFrEF, certainly, clearly demonstrating how different these diseases are.
Again, I think for the ARNI, there was maybe something about patients that had a little bit of lower EF, maybe in the low 40%, as well as the patient that had an elevated BNP or pro-BNP, which is a biomarker, reflecting filling pressure.
Exactly. And I think that's starting to show that potentially HEF with a mid-range ejection fraction, HFmREF, if you will, is more acting like HFrEF than it is like HFpEF. I mean, the median ejection fraction of a lot of the HFpEF patients is closer to 57, so a little bit further away from the 50%. And more, I think we're seeing that division that really 50% divides you from HFrEF below that and HFpEF above. And then we've had some other trials. So TopCat potentially being the most interesting and controversial trial back in 2014, 3,445 patients, half recruited from the Americas and half from Russia and Georgia. And there was significant geographical variation in the results. If you look at the Americas subcohort, there was a benefit to using spironolactone, and the non-Americas subcohort, there wasn't a benefit of using spironolactone. Today in clinical practice, I tend to think that spironolactone is a beneficial drug in a certain group of patients, and really that combination of loop diuretics and mineralocorticoid receptor antagonism forms the basis for our pharmacological management, with any further pharmacological therapies really targeted at an individual patient's risk factor and comorbidity profile, be it the presence of amyloidosis or the presence of atrial fibrillation, etc.
It really seems like in TopCat, the patients that were enrolled in Russia were enrolled because they were admitted in the hospital because of shortness of breath. But the American, and I'm saying North America as well as South America, the patients were enrolled also because of elevated BNP biomarker, really indicating significantly elevated filling pressure. And maybe that's a better way to identify these patients, with HFpEF that really need something like a mineralocorticoid.
Yes, so, I mean, Shane did a great job kind of taking it one step back, did a great job kind of summarizing, all the clinical trials, in HFpEF to date. I just thought it would be good because I think it's an interesting point to bring this up, again, talking about the phenotypes. Everyone was very excited about Paragon, which was studying, Entresto and HFpEF. But, the problem there is I don't think that they did their due diligence in trying to find, the phenotypes of HFpEF that would benefit from Entresto, right? I mean, would you expect a cardiac amyloid patient to benefit with Entresto? No. I mean, in fact, they probably do worse. Would you expect or think like an obese patient would benefit from Entresto? I mean, probably not. An old patient, if aging was there, would they benefit from Entresto? Probably not. So, I mean, I think a lot of these HFpEF trials, and hopefully we've learned from these mistakes, we'll do a better job, sorting out some of these phenotypes before putting together a trial and studying some of these medicines. Now, that being said, I do firmly believe that the SGLT2s in HFpEF patients will actually probably be positive. And that's largely because, the majority of the phenotypes that we currently know, the SGLT2 inhibitors actually help those, right? Those with hypertension, these medicines lower blood pressure. Those with obesity and diabetes, these were diabetes medicines. Those with CAD, probably will benefit from those. We've seen these in the other trials. Those with renal disease, we know the SGLT2s are great for patients with renal disease. And with aging, I mean, maybe they reverse the aging process. I don't know. They've done everything else to date. So maybe they'll make people younger. So I firmly believe, as opposed to, Entresto, that, the SGLT2s probably will be the first, actual FDA approved medication for HFpEF, which would be great for us to finally have a medicine. As we know, TopCat, had its caveat of being positive, but won't get an FDA indication for HFpEF because it technically was a negative trial. But hopefully the SGLT2s will. But yes, so, volume management is a huge part of HFpEF. So we use MRAs, aldactone, eplerenone, as well as loop diuretics or thiazide diuretics in our patients all the time, because volume issues are kind of a universal issue, with these patients, and it does provide symptomatic benefit. I will say as a, kind of a little bonus question, the only FDA approved therapy for HFpEF currently in the US is actually CardioMEMS, which is, something that we've talked about on a previous podcast. So, and, CardioMEMS, as we've talked about, measures fluid in the body. So we do know that fluid is an issue. We do know if patients remain decongested, they do better, which was part of the positive effects of Champion and other subsequent trials. So there are finally some therapies, some treatments that are now around that we can, help offer to some of these HFpEF patients, and hopefully more in the future.
So for SGLT2, we have Emperor, Preserve, and Deliver that are ongoing. Mostly, we're talking about medication like Jardiance and Farxiga being studied. We're still awaiting, for the results, but it looks like it really should be promising. The CardioMEMS, obviously I could see, for example, a patient that has been admitted several times in the hospital. I mean, this is what we see in a lot of these patients. They have preserved ejection fraction, but they've had, 2 or 3 admissions, and really it's very difficult to manage their volume status. And I could see that CardioMEMS would be really a wonderful way to really monitor closely these patients. Jason, I know we've had a podcast on this, but can you give us just a little capsule about, what it is and how do we put it in and how does it measure the pressure in the lungs?
Sure. CardioMEMS is kind of in a group of sensors or devices called pulmonary artery pressure sensors. So the kind of main trial that looked at this was the Champion trial back in 2011 in Lancet. So these are little sensors about the size of my thumbnail that are placed in the pulmonary artery via a right heart cath, usually through the femoral vein. And they are a wireless, batteryless sensor that monitors pulmonary artery pressures. So pulmonary artery systolic pressure, pulmonary artery diastolic pressure, and then the mean pressure. We also input cardiac output that, someday maybe we'll be able to use these sensors to monitor cardiac output as well. But it's mainly related to just the pulmonary systolic, diastolic, and mean pressure. Now, for these patients, hemodynamically, your pulmonary artery diastolic pressure kind of mirrors or mimics your left-sided filling pressures or your pulmonary capillary wedge pressure, which has been discussed before. So we use these monitors, we use these measurements to actually measure, more or less in the lay term, the amount of fluid in somebody's body. And as we all know, one of the kind of cardinal symptoms of HFpEF is volume issues, being able to diurese these patients. Now, as opposed to HFrEF patients, HFpEF patients have a razor thin kind of therapeutic range for their fluid. If they have a little extra fluid, they're very symptomatic. And if they have a little less fluid, they get a lot of renal dysfunction and can get orthostatic and have issues with hypovolemia or low volume. So these patients, run a very razor thin therapeutic range with regards to their fluid. And we have found, and others have found, that the CardioMEMS, pulmonary artery pressure sensor, can provide more exact information, additional kind of objective evidence to someone's fluid status that we found to be very helpful to keep people out of the hospital and to keep their breathing good and their normal activities of daily living as optimum as possible.
Yeah, I agree. I think those two trials, the SGLT2 side and then the pressure sensing side, are potential game changers going forward for HFpEF. Recently, there was the Soloist WHF trial, and that was looking at sotagliflozin, a combined SGLT1 and SGLT2 inhibitor trial. And about 20% of those patients had heart failure with preserved ejection fraction. Not the majority, but certainly a reasonable number of patients. And the benefits of the medication was shown across the spectrum of ejection fraction. Again, emphasizing this idea that SGLT2 inhibitors, as Jason said, are really going to be one of the first medications that will be proven beneficial in HFpEF. From a mechanistic point of view, it makes sense, but also from the evidence point of view. So it's pleasing to see that. And it's a relatively safe medication that cardiologists are now increasingly have become familiar with prescribing as time goes on. When it comes to the pressure sensing side of things, it emphasizes a couple of points. One is that hemodynamics are essential in patients with HFpEF. If you can access those, as useful as the non-invasive testing is, if you can access hemodynamics, it really can be a game changer for patients. And that clearly, when we are made aware of those hemodynamics, either via right heart catheterization or via the device, we change our management decisions. Most of the management changes that were made in Champion were diuretic related. And so we have to think, even if we don't have that pressure sensor, potentially we can use our other parameters, our non-invasive or our clinical examination parameters, to think perhaps we need to be more aggressive with these patients. One point I'll make here is that often we're a little bit afraid in heart failure, but particularly in HFpEF, to escalate our diuretic therapy because of the potential for their renal function worsening. But a lot of these patients have subclinical renal dysfunction. So when they are in their well state, it's important to think about taking some other measures, looking at albuminuria, for example, or measuring phosphate or vitamin D or calcium homeostasis, because you'll find that the patients that have those abnormalities, when you diurese them, their renal function might jump up. And really, their renal function is not that reflective of their true renal function, or the measured renal function, I should say, because they have both sarcopenia and hemodilution as a consequence of their HFpEF. And so when you diurese them, rather than it jumping up higher, it's really just going to their true baseline. So really do keep in mind that don't be surprised if you see that rise. And when they are seemingly in their well state, do take those other measures of renal function to get the full picture of the patient.
I think that is such a good point. And I think I've been guilty of that as well, particularly when the patient is admitted to the hospital. I think we underutilize, diuretics and diuresis because we're afraid of these kidneys. And this is really not good because the patient is in heart failure. You have all kinds of, inflammatory process going on. I mean, really things are getting worse. And I think the formula that has been published was, if they're on Lasix, for example, furosemide 40 milligram, you double it, and then you administer it 2 to 3 times, per day, and really kind of go up and to really increase, the renal excretion and get rid of this volume overload status. Very, very good point. Now, what about another procedure that we hear about is this atrial shunt, and particularly in patients, I mean, here we're dealing with very high left atrial pressure. And if the right atrial pressure is normal or not so high, it would make sense to have kind of a pop-up valve, a small shunt or communication between the left atrium and the right atrium. And it looks like some clinical studies are really coming out that it may be a good option in some of the patients.
We've had the opportunity to be involved in one of those trials, the Reduce LAP trial. There are two main devices available, the V-Wave device and then another, the IASD from Corvia Medical. So both of these devices are creating a hole between the left atrium and the right atrium. If we go back to some of that base pathophysiology, we said that a lot of these patients have left ventricular diastolic abnormalities, so the pressure in the left ventricle rises. That pressure is then passed on to the left atrium, so their left atrial pressure rises. And typically that left atrial pressure then gets put back onto the pulmonary circulation and they feel short of breath. Now, if we could shunt that pressure away from the left atrium before it gets to the pulmonary circulation onto the right side of the heart, then theoretically that is dissipated more onto the right-sided venous system, and patients are less symptomatic from a shortness of breath perspective. And so through a percutaneous approach, usually from the right femoral vein, we're going up into the right atrium, finding the spot on the septum, the connection between the right atrium and the left atrium, to make a hole, and then we deploy this device. Now, in the case of the Corvia device, it's usually a 6mm hole that's being made with a little nitinol metal cage that stays there and endothelializes in, and ideally that hole stays patent for a period of time. Now, how long that is needs to be borne out in clinical trials. And then that 6mm hole allows that pressure from the left atrium to be dissipated across to the right atrium. A couple of key points about this is, one, it doesn't matter how you got to this point of having a high left atrial pressure. We talked a bit before about the different phenotypes and all those different forms of pathophysiology that make people short of breath. But fundamentally, it does come down to this high LA pressure. And so one of the neat things about this device is it is dealing with the physiologic abnormality rather than dealing with all of those previous comorbidities and vascular inflammation and so forth that lead to you developing this high pressure. So it potentially could be used across a wide range of phenotypes. The other important point to keep in mind is that at rest, the pressure difference between the left atrium and the right atrium is not very high. And so theoretically, the shunt won't be doing very much. But at exercise, when the pressure goes up significantly higher in the left atrium, then the shunt will be acting. And so theoretically, it's offering that benefit in a dynamic way, something which diuretics, which we were talking about before, they can't really offer that. We have to diurese a patient at all times, essentially. But there are important negatives to keep in mind. It is an invasive procedure, albeit through a keyhole approach, but still it is an invasive procedure associated with the risks of that. Number two is having that piece of metal in your septum. Does that cause problems downstream in terms of atherothrombosis on that, or thrombosis, I should say, on that? And then finally, is there a risk of developing right heart failure in the long term as we are shunting blood from the left to right? And some early computational modeling studies suggest that that's unlikely to be an issue, but really what we need to see is this long-term data on this. But again, it's potentially a potential therapy that's going to be beneficial for these patients as it's targeting that physiology of high left atrial pressure.
Well, that's great. I mean, but obviously we're still waiting for the clinical trial, and so far we really don't have that many good medication for HFpEF. We're doing the best we can, but we're still medical doctors. We're taking care of these patients, and Jason, we've mentioned, managing this congestion or this edema. We talked about diuretics, and using probably spironolactone in some of these patients, possibly ARNI, not really sure. But what about all these comorbidities that we need to address? I mean, we've got weight management, exercise. Well, how else can we make a difference in the management of our patients?
Yeah, so I mean, those are all great. And this goes back to, wasn't that many years ago where we believed HFpEF to be a lifestyle disease. So we basically, all the recommendations around lifestyle. So for me, my current treatment of HFpEF, remains centered around the control of blood pressure. So including the diagnostic workup for resistant hypertension, when indicated, diabetes, dyslipidemia, OSA, or obstructive sleep apnea, getting patients to our pulmonary colleagues, our sleep medicine colleagues, to get them on CPAP or BiPAP or whatever they think is, beneficial. Chronic obstructive pulmonary disease or COPD, and then volume status, like we've talked about before, with the use of diuretics, mainly focusing on, mineralocorticoid receptor antagonists, loop diuretics, and thiazide diuretics when needed. So in addition to that, along with lifestyle changes, so weight loss, regular exercise, smoking cessation, salt restriction. Salt restriction is a big thing in low EF patients, but also in HFpEF patients. These patients are very salt sensitive. So salt restriction is incredibly important. And we found that, all these interventions can potentially improve the clinical syndrome that is HFpEF. And also with that, which is something that we're very mindful of, is exercise training in patients with HFpEF appears to be safe and is also associated with improvements in, cardiorespiratory fitness as well as quality of life. And I've, seen that before. I also think that there's probably an emotional component to it as well. These patients have not been feeling well, have been depressed, anxious about their diagnosis, and getting out and getting exercise, as we know, can all be, mentally healthy as well. So we'll get a lot of our patients to pulmonary rehab. So, I know it sounds funny that we call it pulmonary rehab, but cardiac rehab is, at least in the U.S., is only for people who have had a stent or people who have a low EF. So unfortunately, in the United States, HFpEF patients kind of get left out in the cold. So one way around that we have found is actually getting them into pulmonary rehab, which is very similar to cardiac rehab, but there's a little less kind of heart monitoring. But regardless, the theory is the same and the exercise training is the same. So for a lot of our HFpEF patients, we get them into pulmonary rehab. And the benefits that we see there, not only objective, like the distances they can walk and how they have progressed in their exercise, both their emotional and psychological well-being is improved as well. And I think that just adds, to the overall improvement, of the patient.
I just want to back Jason up on that and say it is the role of exercise therapy is spectacularly important. In fact, from randomized data, we talk a lot about the failure of a lot of the pharmacological trials. Some of the successes have really been seen with those exercise training, both high intensity, short-term exercise, but also endurance training long-term. And there's no doubt that that has pleiotropic beneficial effects, both on the heart and on the skeletal musculature. And to also reemphasize the psychological impact, a lot of these patients have had unexplained shortness of breath, where they've gone and had several different tests and been told that everything is normal, because indeed the ejection fraction is normal, the chest x-ray at rest is normal, and yet they're presenting to hospital repeatedly with shortness of breath, or they're being told that their comorbidity is the reason they're short of breath. We have patients who will be told it's because you are overweight, that's why you're short of breath, when in reality there is a biochemical and pathological abnormality that we can detect using some of these investigations. So to really back up that it can be psychologically challenging, and so it's really important to support patients through that.
Obesity has so many mechanisms to really give HFpEF. I mean, we know that obesity per se has an increase in plasma volume. The wall stress is increased on the heart. They have hypoventilation, syndrome, or that's sleep apnea, decreased vital capacity. They have a fatty liver that can really cause some inflammation. They have visceral adiposity or the fat pad, central obesity that increases inflammation. Toxic effect of peri-kidney or perinephritic, fat, as well as affecting your skeletal muscle. With fat deposition, the skeletal muscle is not able to use the oxygen as well as it should. And these patients really get short of breath very easily at low level of exercise. And this rehabilitation or exercise, as well as the weight loss, possibly even considering bariatric surgery in some of these patients, could have a tremendous input, into the treatment of these patients.
And on top of all of that, there is also the direct impact of epicardial fat pressing in on the left ventricle. And there have even been some studies looking at, should you do a pericardial snip where you'll cut the pericardium to release that and relax that. Dr. Borlaug did some nice animal studies looking at that. And so I think all of those parts are really important. And when we're advising our patients, the exercise is one big part of it, but also around how to lose weight. And there are many different ways that'll be talked about back and forth, but primarily it's around caloric restriction, and whether that's achieved through a change in the constituents of your diet, or whether that's achieved through intermittent fasting, whatever it might be, having that discussion and getting the right people involved to make sure that the calories in are less than that the calories in are less than your calories out is the way to go. You want to make sure that you are in a calorie deficit so that you can lose the weight.
Certainly in the treatment of hypertension, personally, I think I would try to favor maybe an ARBs like, Avapro or irbesartan, because at least in iPreserve, it looks like some patients could benefit from it, or something like candesartan. It looks like there was some trend towards some, benefit, even though it was a negative trial. What about in patients with AFib? We kind of mentioned them, a little bit. It really looks like those patients would benefit from rhythm control and not so much rate control, but try to get back a normal rhythm. I mean, there's something about losing your atrial kick that really makes you, short of breath. We see that, for example, in patients with aortic stenosis. When they lose that atrial kick and go in AFib, they really totally decompensate. We have the same here in the HFpEF, patient population. Your atrial kick does matter.
Yeah, atrial fibrillation is a quite interesting disease process. It's gone through a revolution here recently. Before, no one really cared about AFib, right? We had, some initial trials that showed, rate versus rhythm control. It's okay just to stay in AFib, and AFib is a benign process, and we just rate control it. That was kind of the old way of thinking. I think breaking down that way of thinking and adding on lots of positive data, showing that AFib is probably not benign. Heart failure cardiologists have known this for a long time, that that AFib is not a benign process. And I think now, especially here with AHA, there was multiple New England Journal of Medicine articles coming out of the benefits of AFib ablation, even up front, and maintaining rhythm control in patients with both, low EF, normal EF, et cetera, et cetera. I think that the world and the medical community is, finally kind of realizing that, we were all born in sinus rhythm. So AFib is a pathologic process, that probably needs to be addressed. Now, probably not everyone will be able to get into a sinus rhythm. But what I do, my personal practice pattern, is I always give people a shot. I never just leave people in AFib, whether it's medications or cardioversion or ablation. We always do our best to try to get, someone back into a normal rhythm. Now, it's not always possible, and there are, exceptions where, rate control, in AFib, is the right choice. But I think that, all fields, EP, cardiology, heart failure, are moving towards probably being more aggressive for AFib and trying to get people back into a normal rhythm. But specifically answering your question, AFib and HFpEF, there's still a lot of unanswered questions. But I would say that in general, doing our best efforts to try to restore a sinus rhythm, with reasonable efforts, rather than just leaving someone in AFib, is probably a pattern that's going to begin to change, throughout the medical landscape.
Let's not forget about myocardial ischemia, which is a very strong contributor to elevate your pressure inside the left ventricle and therefore backing up into that left atrium. And if we do have evidence of ischemia, relieving revascularization or relieving ischemia can be a very significant factor in improving the symptoms in HFpEF patients.
It's really important to keep in mind that the risk factors that lead to the development of HFpEF are very similar to the risk factors that lead to the development of coronary artery disease. So no doubt, as part of our algorithm, when we're seeing these patients with unexplained dyspnea, that we are keeping in mind to exclude coronary disease in whatever form that takes for your local center. And keeping in mind the patient's story of unexplained dyspnea, particularly in certain populations, diabetic people or female patients, that may be the manifestation of coronary ischemia. So we do need to exclude that before making the diagnosis of HFpEF.
Yeah, and I would kind of jump in there as well and completely support that. Not everyone has chest pain. I mean, as cardiologists, we all realize that. We're always surprised at some of the presenting symptoms that people that have, even with ACS and even with STEMIs, hey, doc, I never even had chest pain. I just kind of felt this indigestion or, felt short of breath. And so coronary disease, is what I kind of tell my patients. My practice, we're very aggressive at looking for coronary disease and making sure we get people revascularized because it's fixable, right? I mean, it's something that, for decades we've been able to do stents. The stents are great. The medications are great. Relieving coronary or myocardial ischemia is something that we're very good at in the interventional cardiology world. So it's never anything we want to miss. So for our patients who have a very high pretest probability, sometimes we'll go right to, left heart cath. But for a lot of patients, we will rule out ischemia with at least a stress test, if not going on to a left heart cath, with patients with a high pretest probability, to make sure that we're not missing that, because it isn't something you want to miss, because it's something that's very fixable and patients can, feel a whole lot better afterwards.
And together with that, some of our HFpEF patients who, it's not only is it important to exclude at the start, but remember years later when you're still managing these patients, they can develop coexistent coronary disease. And because of that label of HFpEF, sometimes those symptoms are put down to it's just their HFpEF and we'll change that medication. But particularly when you're starting to see that either the failure of your therapies or you see a sudden change in symptoms, these patients are all higher risk for coronary artery disease because of the nature of the shared risk factor landscape that they have. So really do, as Jason said, be aggressive at the start, but then be aggressive in your screening later on to think about coronary disease in the back of your mind.
Well, if we think about the research in HFpEF, and obviously we're waiting for the trials for SGLT2s inhibitors. Is there anything out there? What should we expect in the next year or two?
Yeah, I think SGLT2s certainly very exciting, as well as the outcomes from the interatrial septal device trials, both in HFrEF and HFpEF, but particularly in HFpEF. We're going to see those come out over the next 18 months. The Corvia trial has closed their recruitment, so we should be able to see some outcome data very soon from that. I think the other thing will be the role of splanchnic innovation. That's becoming increasingly popular. There's a trial now starting with that in the next 12 months that we'll start to see that as a potential therapy for HFpEF. It's not something that's been thought about traditionally before, but from a mechanistic perspective, it may make sense. But of course, it's about how we deliver splanchnic innovation in a safe and effective manner. And we don't want to repeat some of the concerns that were had around renal denervation in the early years. Of course, a totally different therapy, but something to look forward to. The other part is looking at that phenotype-specific treatment. One of the problems with phenotyping these patients has been how you choose to phenotype them. Sanjeev Shah, who's a rock star when it comes to HFpEF really, and a spectacular researcher, he started a lot of this with machine learning back in 2014, I think it was, where you could use machine learning or artificial intelligence to look at a group of patient parameters and then decide to split them up a certain way. But what we've seen is that there have been lots of different papers using both AI methods and non-AI methods to cluster patients. And what we know is that different people look at it differently. And so if I choose to cluster a patient based on their comorbidities, it'll be very different to if I take a blood test and use their genes to separate out patients. And so finding the right method of phenotyping patients is really important, and finding a way that's translatable to the clinic. Because again, if we have to send people off for an expensive genomic test and combine it with 50 or 60 other parameters, that may not be translatable to the clinic. So finding that way of phenotyping patients and then offering specific therapies. Is this the hypertensive phenotype and therefore we offer X therapies? Is this the obese phenotype, so we offer Y therapies? That's where we're really looking at. And so there are some trials looking at how we focus on patients. I'll quickly touch on some other medical therapies just so that people are aware of these. That sildenafil and isosorbide mononitrate were both negative trials. In fact, isosorbide mononitrate reduced physical activity. So you should think about potentially even weaning that off in the appropriate patients. Vericiguat was a trial that showed benefit in terms of quality of life, but not so much in the other respect. So traditionally not really used for HFpEF. Ivabradine didn't show a benefit. And digoxin is a little bit variable, some reduction in heart failure hospitalization, but some increase in angina, so a bit equivocal and really obviously used in those patients. And then neladenazone was a unique therapy that was tested in a Panache trial. Again, didn't show any significant benefit.
Looks like you and Jason are very strong in AI and putting a lot of banking a lot in the future of taking care of our patient with artificial intelligence.
So, I mean, there's a few things that, we're doing, specifically looking kind of at hemodynamics with electronic microscopes and electronic stethoscopes, and trying to use electronic heart sounds and using machine learning to look at that in concordance with hemodynamics, so that you can kind of non-invasively identify hemodynamics using just a electronic stethoscope. So there are, things that, machine learning and AI have been amazing at with just basic tools that we have, including EKGs, a whole host of information that can be generated from EKGs as well as echocardiograms. So very exciting field. I just want to touch on a couple of the different phenotypes that I have a particular interest in as far as the future goes. Again, amyloid, the ATTRibute trials looking at AG10, which is a TTR stabilizer, which will compete with tafamidis. So hopefully that'll drive down costs if that trial is positive, which we believe that it will be. And then, of course, two of the TTR silencers, the Tegsedi or inotersen, and then Onpattro or patisiran, are going to be getting data with cardiac TTR amyloid. Up to this point, it was just the neuropathy associated with TTR amyloid. So hopefully in the near future for cardiac TTR amyloid, we'll have, additional medications that will have FDA approval for that indication. And then lastly, what I wanted to touch on was the pulmonary hypertension phenotype in these patients. So there's a lot of interest in, who group 2 patients, when it comes to pulmonary hypertension, that we've discussed on a previous podcast, may benefit from selective pH-specific therapy. Up to this point, all the trials have been, negative, with a few kind of smaller trials, potentially showing benefits. But I think that there is a subgroup, this, combined pre and post, this out of proportion, pulmonary hypertension to just the kind of elevated wedge patients that I think, do deserve a second look for pH-specific therapy. They're going to have to be very well-designed trials. Everyone's going to have a right heart cath. There's going to have to be probably criteria for defining what is indeed out of proportion. What I believe to be out of proportion may be different than someone else. So defining that so that you can study it would be important. But I do think that there may be a utility for prostanoids and other types of medicines in these patients. So hopefully some of those trials will be ongoing as well. Very exciting field. I think just in my short career, all the advancements that have happened in HFpEF has been fascinating. And, we expect more to come over the next 5 years.
And I think as a patient, it's a really important reminder to be involved in these trials. When we're looking at a field that's had a lot of negative trials in the past, we're now seeing that traditional therapies may not work, and some of these new therapies are really showing promise in a field that's now matured in our understanding. So if you are a patient and you're looking to and you have been diagnosed with HFpEF and have ongoing symptoms, it's a really important opportunity to involve yourself in clinical trials to avail yourself of these latest therapies
and help advance science. So, gentlemen, thank you very much, Dr. Nanayakkara, from Australia, and Jason Guichard from South Carolina. Everything you want to know about HFpEF. Thank you very much, gentlemen. Thank you for taking the time. And I think this was very interesting today.
Thank you so much.
Thank you.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.